All right. Hi, everyone. Happy, as I was saying in the chat, happy almost spring, or nearly spring, I guess, with nice spring weather here in Baltimore. So I hope everyone is doing well. Welcome to our March edition of our Health Equity Jam session. Want to I hope everybody was enjoying the music. But people can put in the chat if they know who the artist was. It's a favorite of our guest today, our guest speaker. Um, so feel free. Um, But I think we can go ahead. I think we've got a critical mass. I think we can go ahead and get started. As you all are thinking about the music we were just enjoying, I think we can go ahead and get started with our introduction of Dr. Warne, Dr. Donald Warne. We will do a. Oh, some folks are saying they couldn't see the chat. Okay. Okay. I think now we can see now. So we will do a more formal introduction of Dr. Warren in a moment, but as in our great tradition of our jam sessions, we wanted to start with some fun facts, and there are some pretty fun facts, I have to say. Um, so first, Dr. Warren is like many people in Baltimore. Uh, Uses a mode of transportation that some people would say could be kind of dangerous. Anyone want to guess what that is in the chat? Rides a bike. Yeah, that could be dangerous. Motorcycle. Uh, we've got a couple of winners here. He is an electric scooter user. Um, and but yet survived to be with us today. So we're very happy. So very good. You can see people have some fun things here. Skateboard, moped. That's good. So very good. So you might see him sometimes on an electric scooter. So Dr. Warren, like many of us in the who work in the health equity space, maybe had some interesting paths leading to this work, and had some previous jobs that might in some ways seem quite dissimilar from what he does now. So one of them, let's see, how can I give a hint? So he was at the time working in Rapid City, South Dakota, and he worked at an establishment that serves food and drink. And we'll invite you to guess in the chat what sort of job he had at that establishment. Okay. Bartender, chef, waiter. These are certainly all the time, all also all some of the things that people do. Card dealer, good one. Bouncer, Janet Jones is the winner. Well done, Dr. Warren. You want to give us some context? Everybody's curious now. Do you want to tell us about your experience as a bouncer?
Yeah, so I'm I'm 6'3" now. I'm 57 years old, but when I was much younger, I think I've gotten shorter now, about 6'4", and played football and very athletic and did lots of sports. I was once upon a time a big, strong young man. This is now, geez, 35 years ago or so. But had a friend who worked at a place called the Oasis in downtown Rapid City, and they needed a bouncer, and I was there for the summer, so I took a job as a bouncer at the Oasis in Rapid City, South Dakota. So
Very
it was
good. Any
a
did you
long time ago.
ever come to blows with any guests that were
I had to
unruly?
separate people, had to separate those types of things, but wasn't too. It wasn't as extravagant as it might sound. It was pretty calm, but a few times just had to calm people down, basically. And
Oh,
the Oasis is still there.
yeah,
Yes, the Oasis
that's what we're
is still
hearing. Okay, thank
there.
you.
Yeah. Yep.
Very
Downtown
cool.
Rapid City. Yeah.
Very neat. Well, so maybe continuing a bit on that theme. Uh, Dr. Warren's parents actually met at a place maybe not dissimilar from the Oasis, right? So at a bar. This particular bar had a requirement of guests. So a guest had to meet some certain really some certain requirement to actually be able to be admitted into the bar. Does anyone want to guess what that requirement was? Costumes? Huh? Had to come in costume, huh? Ah, okay. Show your tribal affiliation. Come with a book. Okay. BYOB. All right. I see age limits, Officers Club. So actually, Nyla, your name is passing by really quickly. Nyla Abdul Baki. Nyla, you are the winner. Do you, Dr. Warren, do you want to tell us about how your parents had to be tall to get into the club?
Yeah, so my dad was 6'4" and my mom was 5'10", and there was like a tall people's club in South Dakota. This is back in the 1960s, or yeah, it must have been early 60s. And as part of the tall people's club, they would do various things, like have a night out at a bar or go bowling or what have you. And it was kind of a social way for tall people to meet each other. But that's how, yeah, my mom at 5'10" and my dad at 6'4" met in Rapid City, not too far from the Oasis, actually, many, many years ago in the early 60s.
Oh, Dr. Cooper self-identified as somebody that would not get in the club. Poor Dr.
Yeah,
Cooper.
yeah.
But
I think it was like 5'9" minimum for women and 6'2" or something like that for
nor
men.
would I. Okay.
Yeah,
So
yeah,
very neat. Well, thank you all for participating, and thank you, Dr. Warren, for sharing these super fun facts. So we want to give a sort of more fuller introduction of you. So Dr. Warren is a professor of public health and the provost fellow of Indigenous Health Policy and co-director of the Johns Hopkins Center for Indigenous Health. He's an enrolled member of the Oglala Lakota tribe in Pine Ridge, South Dakota. And he comes from a long line of traditional healers and medicine men and is a celebrated researcher of chronic health inequities. Given that he's a scholar in Indigenous health, health education policy, and equity, he was able to lead a team that created the first Indigenous health focused Master of Public Health and PhD program in the US. And that was based at the University of North Dakota. And so we are super thrilled to have Dr. Warren here with us today. I had a chance to meet him virtually. We've only had a couple of interactions now. They've both been virtual, but over the summer he spoke to a group of our summer students here at Hopkins. And was a big hit. And so I thought our Center for Health Equity colleagues would also enjoy hearing from him. So welcome, and we look forward to hearing your talk.
yeah. How Pilamia Yellow Mitakuipi. Hello, thank you, and welcome to all my relations here today. I'm very pleased and honored to be a part of this lecture series and these important discussions around equity. And I'm also excited to see Indigenous perspectives brought to the table and acknowledged as part of the long-term solutions as a society. So what I'll talk about today is our Center for Indigenous Health, but also share some of my own thoughts and ideas in terms of how we could um, steps forward collaboratively to improve health equity for Indigenous populations. So I'll do my presentations like maybe 45 minutes to an hour, but leave plenty of time at the end if there's discussion and Q&A. So again, just so pleased to be a part of these important discussions. I'm actually connecting in from Las Vegas, Nevada right now. There's what's called the Reservation Economic Summit, and it's about 2,000 people here. And I was able to present this morning on the idea of developing an Indigenous School of Medicine. And there's a big movement trying to indigenize health education and health profession training programs. So we'll talk a little bit about that, as well as what we're doing here at Johns Hopkins in terms of developing what will be the world's first DRPH with an Indigenous health focus. So there's a lot of exciting things that we're working on. We'll cover an overview of our Center for Indigenous Health. It has a very interesting background and origin. Then we'll look at terminology, because I think many people use the terms American Indian and Native American interchangeably, but they actually do have different legal definitions. So we'll just make sure we're all on the same page in terms of the terminology. Then we'll talk about the impact of historical trauma and unresolved trauma and how that has an impact on health disparities today. And that if we are to generate meaningful public health interventions, we have to acknowledge and be mindful of the impact of historical trauma on the entire population. So then we'll look at some contemporary challenges and potential solutions. And as I had mentioned, plenty of time at the end for discussion. So our Johns Hopkins Center for Indigenous Health was the Center for American Indian Health, established more than 30 years ago, so starting in 1991. And the reason this started through Dr. Matu Santoshem, and you might know Matu. He is a pediatric infectious disease physician and researcher. And in the early 1980s, he was asked by one of the tribes in Arizona to assist them with this terrible challenge they had of babies and young children dying from dehydration due to infectious diarrhea. So it's a very rural and impoverished community. There's no pediatric intensive care unit. So even just getting IV fluids is a challenge. So these young children were dying from dehydration, just a horrible story. So he and a team from Johns Hopkins went out to that tribal community to develop an oral rehydration solution, and that eventually became Pedialyte. So if you've ever used Pedialyte, that actually comes from the Center for American Indian Health at Johns Hopkins. So he's very generous and very much community focused and equity focused. So he is the one who actually established the Center for American Indian Health in 1991. So in the last year and a half, we've expanded our focus to beyond just the United States. So that's why we are now a Center for Indigenous Health, focusing on Indigenous populations in many parts of the world, and I'll talk about that. So our mission is to work in partnership with communities to advance Indigenous well-being and health leadership to the highest level. And recognizing that we can't do work on communities, we have to do work with communities, right? So much of the work is community driven. The priorities are community driven, and much of our programming was really generated out of a community-based and participatory process in which the communities would tell us what their priorities are and what their concerns are, and then we would be responsive to that. So really working in partnership is a key component of connecting with our populations in a meaningful way. And then the vision is thriving Indigenous communities worldwide. And unfortunately, we see terrible disparities across the world when we look at Indigenous populations and the long-term impact of colonization and marginalization, loss of traditional food systems, loss of traditional medicine, loss of culture and language. All of those things have had an impact on public health. So we want to try to do our part in helping to reverse that trend and focus on strength and improve outcomes. So this is the area of work that we do through our center. So we have a policy and advocacy arm of what we do, and I lead that. So I'm the co-director of the center. So what falls under my purview is the policy and advocacy side, as well as education and training. But in terms of policy and advocacy, we know that everything we do in public health is really determined by policymakers at some level, whether it's Congress or legislatures or agency directors or even the private sector developing policies. Health policies tell us who gets health services, what those services are, and how those services are delivered. But for American Indians, we also have to recognize tribal sovereignty and the fact that there's a separate system of governance through tribes, and that has to be respected and integrated. So when we're looking at national policy like Medicaid expansion, we know that, of course, was a federal policy through the ACA, but it's still up to the state legislatures as to whether or not they pass Medicaid expansion, for example. And then it's up to the tribal nations to do the third-party revenue generation and actually run clinics. So there's multiple levels of government to work with when we're looking at American Indian health policy. And then internationally, I do a lot of work with the United Nations, and they have what's called the UN Permanent Forum on Indigenous Issues. We developed a document called the Indigenous Determinants of Health. So not just social determinants and deficits base, but also recognizing the strengths base of having cultural connectedness, language preservation, participation in ceremonies. All of those things are actually protective of health. So the policy and advocacy work is done at many levels, internationally, nationally, at the state level, the tribal level, and in the private sector. In terms of education and training, we've had educational programs through the center for many years, and we have a summer institute and a winter institute with public health certificates in American Indian health and now Indigenous health. And as I had mentioned, what's very exciting, we're in process of developing an MPH specialization in Indigenous health, but also a DRPH specialization in Indigenous health. So it will be the first DRPH in the world right here at Johns Hopkins with an Indigenous health specialization. And one of the reasons that's important, and maybe even speaking about some of the work that you do, um, and some of the students that we have and the curriculum that we have, quite often we don't include Indigenous data in our courses. I mean, even thinking about biostats and epidemiology, is we still see data sets that say Black, white, Hispanic, and other. You know what I mean? We don't even look at some of the Indigenous data. And then certainly the policy issues that are so unique among American Indians. So, um, and I think I don't know if there's a hand that was raised or not, but if there is, please feel free to either put something in the chat or let us know if you have any questions or comments that you wanted to address. But very good. So another part of what we do, of course, is research and evaluation. We have a huge research portfolio, tens of millions of externally funded research, and I'll talk a little bit about that. But our research portfolio really is community driven. So I think quite often what we see in many of the populations we work with, the researchers and the academics develop research questions and hypotheses, and then engage communities and say, here's our idea, will you participate? So in a way that's community participatory, but it's not community driven. So our approach has been, what are your priorities? And then we'll identify the resources to pursue it. So really community driven research processes. And then of course, we're all aware of best practices and evidence-based practices. And whenever I say that term, evidence-based practice, my question is always, whose evidence is it, right? If we have an evidence-based practice that was highly effective in New York City or Baltimore, does that mean it's going to be highly effective in a rural tribal reservation? Well, it may or it may not be. So we have to be cognizant of the fact that evidence base is developed in particular contexts. And each tribe has its own context, historical context, linguistic context, cultural context. So in a wise practices approach, we're looking at evidence-based practices, but recognizing that it needs to be culturally adapted. So we can't just take a program off the shelf and implement it in a tribal community and assume it's going to work. So the whole wise practices movement actually comes out of Canada. If you're interested, you could just Google wise practices. And there's really good processes now for Indigenous cultural adaptation of the work. So just very exciting things that we're working on. So in terms of our scope, in the US, we're working with tribal nations all over the country. We've now worked with over 160 tribes in the US. And of course, Hopkins is based in Baltimore, and we have over 300 employees, but the vast majority of our center employees are not in Baltimore. So we have a Southwest hub that includes sites primarily in Arizona and New Mexico. We have a Great Lakes hub with a lot of work going on with the northern Midwest tribes out of Duluth, Minnesota. And we are now in process of developing our Great Plains hub, which will be in Rapid City, South Dakota. And we did just recently get an NIH other transactions grant to establish a holistic diabetes program with American Indians living in Rapid City, South Dakota. And that just got started March 1st. So a lot of work going on, and we're expanding our scope to the Great Plains. So we'll update this slide to have a pin in Rapid City, South Dakota very shortly. So the majority of our employees are Indigenous. Over 90% of the team works actually in the communities, not necessarily right in Baltimore. And as I had mentioned, we've worked with over 160 tribes in the US, but now we're working with Indigenous populations in New Zealand, Canada, and Australia. So you may have heard last year we were awarded a huge grant from the Lego Foundation. So Lego, the toys, and until this particular grant opportunity, I had no idea that Lego had a foundation, but they do. And Lego is actually based in Denmark. But the Family Spirit program is a home visiting program that is focused on maternal and child health and looking at high risk pregnancies and having culturally adapted and culturally relevant uh, um, parenting skills, education, and life skills components, and making sure that we're creating as healthy a family environment as possible for an infant to be brought into. And it's now an evidence-based practice. We see significant improvements in maternal and child health outcomes for those who have gone through the Family Spirit curriculum. So again, it's home visiting, it's hiring and training community members to basically be community health workers focused on maternal and child health. So many of you might be familiar with McV, the Maternal, Infant, and Early Child Home Visitation Program. Family Spirit is kind of like McV on cultural steroids because it's really focused on culturally relevant approaches to promoting maternal and child health. And again, evidence-based. So we had partners and communities in Australia, New Zealand, and Canada that were very interested in expanding Family Spirit to their population. So that grant was a $30 million grant, actually, to expand Family Spirit around the globe. So a lot of exciting work going on internationally. Let's look at the terminology that we use. And, for races and ethnicities in the US, it's actually the Office of Management and Budget that decides what the official races and ethnicities are. Why it's OMB, I don't know. I'm not really sure why. It's Office of Management and Budget that determines this, but that's the federal agency that describes or defines the races and ethnicities. So in the US, there are several races and one ethnicity that's formally recognized. So you're either Hispanic or non-Hispanic. That's an ethnicity, not a race. That's why you'll hear the term non-Hispanic white, for example. And then the races, of course, include white or Caucasian, Black or African American, American Indian, Alaskan Native, Pacific Islander, and Asian American. And we're called American Indian and Alaskan Native because if you look at the US indigenous people in North America, that's American Indians and Alaskan Natives. So the reason Alaska Natives are separated out is that some of the Native Alaskan peoples are American Indian culturally. So for example, Athabascan groups in Central Alaska are linguistically tied to indigenous populations across North America. So even Navajo and Apache tribes linguistically are Athabascan. But if you go further north, the Inupiaq or Inuit populations, those are not American Indian cultural groups. The Inupiaq peoples are more of a circumpolar cultural group. So you have Inupiaq people in Siberia, Northern Alaska, Northern Canada, and Greenland. So they're not American Indian, but they are indigenous to Alaska. So that's why it's called American Indian and Alaskan Native. So I'll put a question you can answer in the chat if you'd like to, but why are we called Indians? Does anybody know? Why are we American Indians? Any thoughts on that? Why there's an Indian Health Service, a Bureau of Indian. Yep, exactly. Very good, Sherry. Exactly. That Columbus thought he was in India. So that's why we have the West Indies. That's why we have Indian tribes. That's why we have an American Indian. So I'm an Indian because Columbus was lost at sea. Isn't that fascinating? But then why are we Americans? Does anybody know where the word American comes from? Any thoughts on that? It's exactly very good. All right, great. They got all of them right. So Amerigo Vespucci was another Italian explorer, and he named two huge continents after himself. So America comes from Amerigo. So Amerigo Vespucci was another Italian explorer who named North America and South America after himself. So it's really interesting. Every time we say the term American Indian, we're actually paying homage to two Italians. Vespucci, and Columbus. Isn't that remarkable? So that's the origin of those terms as American Indian for our population. So that's the racial group. So there's another subpopulation of enrolled tribal members. So I'm an enrolled tribal member of the Oglala Lakota Nation from Pine Ridge, South Dakota. And it is a nation within the nation. We actually have 574 federally recognized tribes. So each of those tribes is a sovereign nation. So we have nations within the nation. And as an enrolled tribal member, that's not a racial designation. That's actually a political designation, much like you can be resident of a state, like I'm a resident of Maryland, for example. That's not a racial designation, that's a political designation. So we have this unique political status if we are enrolled in our tribe. So in many ways, we have a tri-citizenship. We're citizens of our tribal nation, citizens of the US, and residents of the state in which we live. So our health system is very complex. So I'm eligible for Indian Health Service because I'm an enrolled tribal member. But as an American, I would be eligible for Medicare when I reach qualifications. And if my income was low enough, I'd be eligible for Medicaid as a state resident. So we have multiple health systems that don't always work together as effectively as they could. We also hear the term Native American, and I see a lot of people who use the term Native American interchangeably with American Indian. But the Native American population was actually legally defined in 1978 in the Native American Programs Act, or NAPA, Native American Programs Act. So Native Americans are American Indians and Alaska Natives, but also Native Hawaiians and other Pacific Islanders who are territories of the US. So American Samoans are Native American. The Chamorro Indigenous people of Guam are Native American because they are part of our nation, right? They are part of America, so they are Native American. So we just have to be cognizant when we're saying Native American, we are being inclusive of Pacific Islander Indigenous peoples. So if we really just mean North America, we should be saying American Indian, Alaska Native. And if we're talking about just South Dakota, it's American Indian. So I know it can get relatively complex just looking at the appropriate terminology. And then, of course, the term we use now for our global work is Indigenous. And indigenous, the term comes from the Latin indigena, which means of the earth or from the earth. And the indigenous peoples are the original inhabitants of various parts of the globe. So that's why we use now the term indigenous. And what we tend to see is the impact of colonization having an intergenerational impact on the health of indigenous peoples. And we'll look at the US kind of as a case study of what happens when indigenous peoples are colonized. So this is just looking at the lower 48 states. And of course, it was all Indian country at one point, right? We had tribal nations all over what is now but the United States. But of course, we've seen a lot of changes in terms of our territories and our connectivity to sacred places. And many tribes have been essentially eliminated, and some of the tribes were removed from their homeland. So what is the impact long-term on intergenerational public health when we have this pattern of loss of territory? So we have to think of this in terms of historical trauma. And when we use the word trauma, we have to really be mindful of what we mean. So trauma, of course, can be physical trauma, like a trauma center for physical injuries. And there's been a lot of research in recent years, as I'm sure you are aware, in psychological and emotional trauma, things like adverse childhood experiences. And what does that childhood trauma do long term for the health of individuals? But I'd say that for Indigenous peoples, we've also had spiritual trauma. And what I mean by that is that it's a little known fact, but our traditional religion was actually illegal for about 100 years in the United States. Something else you could Google if you're interested is the Code of Indian Offenses. Code of Indian Offenses. And basically, that was a list of things that were illegal for tribes to participate in, including medicine men. Traditional healers were made illegal. One of our sacred ceremonies, the sun dance, was specifically called out as against the law, punishable by withholding food and imprisonment. So you can be incarcerated and starved if you practice your traditional religious practices. Isn't that remarkable? And think about one of the founding tenets of the United States being freedom of religion. If we're honest about it, it was freedom of religion for most Americans, but certainly not Indigenous Americans. We did not have freedom of religion until 1978 when we had the Indian Religious Freedom Act. And isn't that remarkable? We actually had to have a law that allowed us to practice our own religions in an open manner. So there's all kinds of traumatic events, not just physical, psychological, and emotional, but also spiritually traumatic events that still have an impact. If we think about the population going back to the time of Columbus, of course, it was all Indian country. And then colonization is a part of our vernacular when we talk about the US, because we talk about the US colonies, right? So those are literally the colonies where colonization occurred in what is now the Northeast of the United States, including right here in Maryland, right? So we have to be cognizant of that. There are Piscataway and other tribal groups right in Baltimore that were deeply affected by colonization. So I'm sure people are familiar with Amherst, Massachusetts, Lord Jeffrey Amherst. Maybe in the chat, anyone know what is Amherst famous for in Indian country? Any thoughts or ideas? Yeah, Jeffrey Amherst. Not seeing any ideas. Let's move forward. So Jeffrey Amherst is well known in Indian country. The colonial leader who actually ordered the distribution of blankets from a smallpox hospital to the tribes in the Northeast with the purpose of killing them. So our first documented case of bioterrorism, the intentional spread of smallpox, is Amherst. And this is something you can Google as well. Just Google Amherst smallpox. You'll find this letter that he wrote. And it's in cursive, from a long time ago, but this is what he said. He said, "You will do well to try to inoculate the Indians by means of blankets, as well as to try every other method that can serve to extirpate or get rid of this execrable or horrible race. Extirpate this execrable race." Look at all the hatred embedded within that statement. "I should be very glad your scheme for hunting them down by dogs could take effect." So this is from the pen of Lord Jeffrey Amherst, and it's really remarkable because what do we do now? Well, we honor him, right? We have cities named after Amherst. We have UMass Amherst. We have all of these things that we do to honor Jeffrey Amherst, but he murdered Indigenous peoples in the Northeast, and many, many, many thousands died from smallpox, and it was the intentional spread. So this is something we have to be cognizant of, and it's really disappointing how poorly taught and organized our history books are, isn't it? That we don't cover these types of pieces of information. But it's important to understand, why is it that there are so few Indigenous peoples in the Northeast? Well, there are reasons for this, and a lot of it has to do with using infectious disease as a weapon to actually get rid of many of the tribal nations in what is now the Northeast. So I talk about these things, and it's not for the purpose of making anyone feel bad. So please understand, it's not that I want anyone to feel bad about what's happened. That's not the point. I talk about these things because it's the truth. And I know this is an equity-focused group, and I really believe that if we are ever going to get to equity, we have to walk through truth, even when it's unpleasant, even when it makes us uncomfortable. So much of this discussion is difficult to talk about and think about, but it is our truth, and it is the basis for the inequities that we see now among Indigenous peoples, particularly here in the US. So in 1830, there was a law called the Indian Removal Act. And think about that, just the racism built into the name of the law, Indian removal. So it's a law that removed tribal members from the southeast of the United States to what is now Oklahoma. And it's more colloquially known as the Trail of Tears. You may have heard of that, the Trail of Tears. And in this process, a really interesting dynamic occurred in which many of the tribal members were removed to Oklahoma, but many of the tribal members refused to leave and actually stayed in their homelands. So that's why we have this interesting dynamic now where we have Seminoles in Florida and Seminoles in Oklahoma. Cherokees in North Carolina, Cherokees in Oklahoma, Choctaws in Mississippi, Choctaws in Oklahoma. So you get the idea. And of the 38 federally recognized tribes in Oklahoma, only 4 of them are actually from Oklahoma. The rest of them were removed from other parts of the country. So think about that in terms of food systems. Something as basic as access to homelands and traditional foods, and then being removed from your homelands, completely disrupting your food sovereignty and your economies, and then becoming dependent on the federal government for food. And food was again used as a weapon. So if you were practicing your traditional religion, your food would be withheld. It's just that simple. So really significant challenges for the southeastern part of the United States during that time frame. The discovery of gold in 1849 was just devastating to the California tribes. The vast majority of the California indigenous population was wiped out by the late 1800s because of the gold rush. So just a really bad outcome for many of the tribes there. But we have to look at this in a holistic manner and recognize that there's all kinds of challenging history that we deal with, and there was genocide. And some people in certain sectors are uncomfortable with that term genocide, but that's exactly what it was. And we have some tribal nations that no longer exist. They were completely wiped out through warfare and spread of infectious disease, and in some cases, intentional spread of infectious disease. So we have a history of genocide in which millions of American Indian people were killed during that process of colonization. Part of the playbook, for lack of a better term, particularly a British colonization, is developing boarding schools or residential schools. And the whole idea of the boarding school is to remove children from their families, put them in schools far away from home, and teach them how to not be American Indian anymore, not to be Indigenous anymore. So it really was a process of trying to get rid of the culture. And the way that families were compelled to give up their children to go to boarding school is that they were told, either give up your children or we will withhold your ration. So give up your children or starve was the option. And as a result of that, unfortunately, we have many, many thousands of American Indian, First Nations, Aboriginal, Maori children around the world. Again, wherever British colonization occurred, boarding schools occurred. And these children were then taken away, in some cases, more than 1,000 miles away from home. This is a picture from the Carlisle Indian School in Carlisle, Pennsylvania, not too far from Baltimore. And this is a class photo of many American Indian kids at Carlisle Indian School. And I have 4 kids, and I've seen lots of class photos, and I usually see laughter and smiling and joy. And I look at these poor, beautiful, innocent little children. I don't see any of that. I see anger. I see fear. I see sadness. And we had, again, thousands and thousands of American Indian children who went through these boarding schools. And it's not ancient history. My mother is a survivor of boarding schools. And the types of abuse that occurred in these schools was just awful. We have this intergenerational outcome of terribly traumatic events to an entire generation of Indigenous people. This is a picture of the graveyard next to Carlisle Indian School. And all of these boarding schools have either marked or unmarked graveyards. Many, many thousands of kids died at boarding school. And we don't know exactly why so many died. We know that there were outbreaks of things like tuberculosis and influenza, but it doesn't answer why there was so much excess death. So many of those kids never came home. And again, we'll probably never know exactly why so many of them died. But thinking about that, what about the survivors? What is the emotional, psychological, and spiritual impact when you're a child and so many of your friends and classmates are dying at such an unnaturally high rate? Incredibly difficult things to consider and to think about. But again, it's part of our truth. It's part of our history. And if we don't have a good understanding of why we have inequities, we're never going to develop meaningful solutions. So very challenging, but it's part of our history that needs to be better understood. So some of the considerations as well is that the stressors are not occurring just historically. So we unfortunately also have had I would say probably some nutritional epigenetic changes to our population because of bad food. So um, the WIC program, Women, Infants, and Children, historically, at least in the reservation communities where I worked and lived, the WIC program was basically a baby formula distribution program, handing out baby formula. And we know that as a population, formula fed children grow up to have higher rates of diabetes than breastfed children. So, in fairness, WIC is doing a much better job now of promoting breastfeeding than they did 20 years ago. But many decades of damage has been done by having excessively high rates of formula feeding in reservations. Because when you think about the culture of poverty, if you're giving something that's relatively expensive, like baby formula, for free to an impoverished new young mom, is she going to take it? Well, yes. And what we wound up seeing is a disparity in the rates of breastfeeding among American Indians during this time frame because WIC was handing it out for free. And just even think about the word formula. I mean, does that sound appealing to anybody? Come on over, we'll have lots of formula. I mean, it's formulated in a laboratory, right? So formula feeding is actually not good for public health. And historically, I mean, not every woman can breastfeed, right? Some women have problems with that. And that's just a part of our normal natural history as human beings. So what we did in our tribal communities and other indigenous populations is have wet nurses. There were women who would breastfeed for other women who couldn't. So it's a communitarian approach, right? That we would look at the needs of our community in a holistic way, and we would help each other. That's basically what we did. So that's for formula. And then the FDPIR is the Food Distribution Program on Indian Reservations. And the FDPIR, also known as the Commodity Food Program, it includes very unhealthy food historically. So when we think of traditional American Indian food now, a lot of people think of fry bread, right? Indian fry bread. And there's a child with a big fry bread on the left, and you can see the elder on the right using commodity foods from the USDA to make fry bread. So the origin of fry bread is not culturally in indigenous populations. The origin of fry bread is people doing the best they can with the food that was distributed to them from the USDA. So when we say it's traditional food, it's not traditional indigenous food, it's traditional USDA food, right? And look at that. That is basically pre-packaged diabetes. And we wonder, why do we have such high rates of obesity and diabetes, some forms of cancer, and certainly heart disease? There are policy-based reasons for this. And I would put forth that one of the worst policies historically was the unhealthy foods that were provided in the commodity food program. And here's some pictures of them. This is stuff that I grew up with. I remember the canned beef and canned pork, almost spam-like meat products, but not as good as, which sounds amazing to say. Commodity cheese, ultra-processed cheese with lots of preservatives. They used to distribute what they called grape juice, but I think it was just sugar water with purple food coloring. On the right, people are shocked by this in many cases, but that big container on the right here, that's a large container of corn syrup. And we know that corn syrup is an unnatural sweetener. It is highly processed and it is formulated. It's unnatural engineered food. But if you look in fine print, it says right here, used in baby formula. Isn't that remarkable? So our USDA telling us to use corn syrup in baby formula. And then we wonder, why do Indians have high rates of diabetes? It's right here in front of us. And I am honestly disappointed, I think, in the public health educational arena for not knowing this, right? This should be part of what we teach. And if we have epidemiology classes focused on diabetes, there are reasons for it, And if you look at NIH, they want to find the gene responsible. I'd say there's not a gene responsible, but you can get a lot of answers just by looking at the label of USDA commodity food. So that's kind of going through this historical timeline and moving forward. I'm sure many people, if not everyone, is familiar with the ACE study, Adverse Childhood Experiences study, and really a groundbreaking study in the 1990s showing that the more adversity someone experiences in childhood, the worse their health status is as an adult. And I was the co-principal investigator in what was called the South Dakota Health Survey, and we included a lot of validated survey questions, and we included the ACE study. And in every report I've seen, unfortunately, American Indian populations have higher ACE scores than non-Indian populations. So what we wind up seeing is, in addition to all of this historical trauma, we wind up seeing adverse childhood experiences that lead to additional disparities, unfortunately. And we know, again, ACEs, adverse childhood experiences, have long-lasting effects, and it's in a dose-response manner. Whereas the more adversity or the more types of adversity, the worse the health outcomes, but also risk factors, higher rates of smoking, higher rates of addiction, and also an impact on life potential. We see higher rates of poverty, higher rates of dropout. So adverse childhood experiences are really a vital component of understanding the current disparities and challenges. So I'm sure many of you have seen the ACE pyramid, and usually the ACE pyramid has adverse childhood experiences at the base of the pyramid. But I'm very proud of my friends and colleagues at CDC, particularly the National Center on Injury Prevention, because they updated this. And now the base of the ACE pyramid says generational embodiment and historical trauma, recognizing that historical trauma in a population can lead to the local conditions in which some families and populations are at greater risk for adverse childhood experiences. So recognizing that it's not just the fault of those young parents as much as it is a societal and intergenerational issue that leads to risk for adverse childhood experiences. And then with ACEs, we see disrupted neurological development, social and cognitive impairment, adoption of high-risk health behaviors, and then early onset of disease, disability, and death. So just terrible outcomes when we look at adverse childhood experiences. And then, of course, the adversity does not end at age 18, right? We still see, unfortunately, challenges related to adversity in adulthood and toxic stress. And living in impoverished communities is stressful. Living in communities in which there's discrimination and marginalization and racism, that is highly stressful. So we have populations of people living under these circumstances in which their cortisol levels are high, their inflammatory markers are high. And again, that leads to additional risk for things like diabetes and heart disease. So we have to be much more holistic in our understanding. And we're not going to find a gene that explains this, right? There's historical, policy, programmatic basis for the inequities that we observe. Going back to this medicine wheel and thinking of it more holistically, that when we think about healing from all of these challenges, and again, it's in a way depressing to see all of those negative inputs, but in truth, we also have many places where we can intervene. That's why things like family spirit are so important. That's why community-driven public health programming is so vitally important. And when I think about the healing process, obviously we need to have physical healing process. I'm a physician, so trained in physical medicine. Physician, physical have the same Latin root, physic, meaning the natural sciences. But when we think about all of those disparities and all of those challenges, we're not going to be able to prescribe our way out of that disparity, right? The solutions are not in the pharmacy. The solutions are in the community. So we have to focus on holistic healing. And that includes mental health, emotional health, and spiritual health. And there's some really compelling early research, kind of on a smaller scale, that is showing some really positive outcomes. So even the impact of prayer and feeling connected to a higher power, that's associated with a better sense of wellness in populations. We know that meditation and mindfulness is also helping address some of the stress hormones and blood pressure. CBT, cognitive behavioral therapy, is being mindful of what we are thinking about and what we're what we're conscious of. So what's really interesting with cognitive behavioral therapy, what we see is that when people are thinking about something that makes them angry, it can increase blood pressure, it can increase epinephrine, it can increase cortisol. But when people are really mindful and thinking about things that they're grateful for, we see improvements in physiology to such a degree that if it was in the form of a pill, it would be standard practice. But because it's mindfulness, it's alternative medicine, right? But when I hear those stories and those studies, it makes me think about what I was taught from a very young age about morning prayer and being mindful every day of what we're grateful for and having gratitude. And these are things that could be scaled up. I mean, they're culturally relevant interventions that could have a real meaningful impact. We also know that physical activity is good not just for physical health, but also behavioral health. We see better emotional and mental health when people are more physically active. So, how do we promote that in a culturally relevant way? And then also social connections in the emotional arena. Social isolation is actually bad for our health, and there's some really good studies to support that. And during the pandemic, I wish we had never used the term social distancing, right? 6 feet is a physical distance, not a social distance. If anything, we needed more social connectedness during this time frame, not social isolation. So I think having that web of connectivity, in Lakota we say mitakue oyasi, which means we are all related or we are all connected. And having that sense of connectivity to family and community is incredibly powerful. And these need to be part of our solutions as we're moving forward. So some considerations and challenges to think about. One consideration is just the contributions of American Indians and Alaska Natives to US public health. And I had mentioned the efficacy of oral rehydration solution. That was developed through Johns Hopkins and the Center for American Indian Health at the time, and eventually became Pedialyte, right? So the origin of our center is Pedialyte, essentially. Many of the routine vaccines were also tested in tribal populations, and including COVID-19 vaccine. Also, diabetes management. Many years ago, when I worked for NIDDK, I was a staff clinician for NIH and National Institute of Diabetes and Digestive and Kidney Disorders. And we did the DPP. So I was a co-investigator on the DPP back in the late 90s and early 2000s. And we showed how holistic approaches and lifestyle support could actually improve diabetes management and blood sugar control even better than medications, right? So we know these things, we just don't seem to scale them up in terms of our policies and funding mechanisms for managing chronic diseases. We also need to promote more respect for Indigenous healing systems, Indigenous science, Indigenous medicine, and methodologies. So even think about botanical medicine. Can anyone tell me, maybe in the chat, where does aspirin come from? Does anybody know? Acetyl salicylic acid. Where does that come from? Willow bark, very good. Yeah, not bark, it's actually willow tree bark. So we've been using willow bark for thousands of years as indigenous peoples here in the US. So willow bark tea is basically aspirin, right? So the chemists would call it an aqueous solution. We call it tea, right? So it's a willow bark tea. So it was a traditional medicine until Bayer discovered it, and now it's a modern medicine, right? So, quite often I get asked, are there any hospitals in the US that are doing a good job of integrating traditional indigenous medicine? And my answer is yes, every single one of them. Because if you go to the hospital and they suspect a heart attack, what's the first thing they do? They give you willow bark tea, but in the form of an aspirin, right? But that's traditional indigenous knowledge. That's our science that's been co-opted. I'm sure people are familiar with osteopathic medicine, right? The father of osteopathy is A.T. Still. And he grew up in Missouri and he learned osteopathic medicine from Shawnee and Oto Indians. So it's the whole field of osteopathic medicine is traditional American Indian medicine that got co-opted. And now it's basically a whole separate system of healing. But we should recognize this is indigenous STEM, it's indigenous medicine. Some challenges. We have disparities pre-K to postdoc, right? So we need more early childhood interventions. We need the pathway through education to include residencies and postdoc opportunities. And one of the things that we're doing internationally right now is working with our international collaborators to develop an international Indigenous health postdoc. And it's really exciting. It would be a 2-year postdoc. And the postdoc students would have a menu of options to spend 6 months each in either Australia, New Zealand, Hawaii, Alaska, Canada, US, or Norway. Wouldn't that be remarkable? I wish I could do that postdoc actually, but it'd be training from an international perspective. Another challenge we face, we have few role models in public health leadership, very few role models in higher education. So maybe in the chat, how many deans of medical schools in the US are American Indian? How many American Indian medical school deans are there today? Right, exactly. Zero. Yes, it's less than one. You can count them on zero hands. There's none. So we're not even at the table when we look at developing curricula. Now, the same question, how many public health school deans are there that are American Indian? Public health school deans, how many American Indians? Zero again, exactly. Is that acceptable to people? Is that a problem? Is it a crisis? So when we think about this, we're not underrepresented, we're unrepresented in these arenas. And that's something that's got to change. And that's why our educational and leadership development programs are so vitally important to our Center for Indigenous Health. So we need to change these things. We need to develop the next generation of academic leaders in addition to clinicians. Other challenges with poverty, societal and global problems. And of course, we tend to take a one size fits all approach, with our evidence-based practices. But again, whose evidence is it? And we need to build the Indigenous evidence base. So as a equity group, I'm sure you've seen this slide or very similar slides or images looking at the difference between equality and equity. And I like this image because on the left, equality, everyone gets the same package of services. So everyone gets the same curriculum in medical school. If for your Medicaid plan, everyone gets the same package of services. Whether or not it meets your needs, everyone gets the exact same thing. And as a result, we have people who wind up being underserved, right? So the equality approach is looking at the process from my perspective, and we're looking at everyone gets the same thing, whether or not it works. Whereas an equity lens allows us to recognize that each population is different, individuals are different, and perhaps our systems need to be more intelligent and work harder to respond to those individual needs. And with this image, that package of services, the guy on the left didn't need it, serving the one in the middle pretty well, the guy on the right is still underserved. But through an equity lens, we can recognize that our programming should be and can be more diverse to reflect the needs of the people that we are trying to educate and serve. So I've been showing this image for many years, and a few years ago, someone sent me a picture I think is just brilliant. And the question is, what is that fence doing there in the first place, right? That perhaps it's not just the package of services to overcome the barrier, but maybe we need to get rid of the systemic barrier. And I would put forth that one of our challenges as a systemic barrier for Indigenous peoples is just simple lack of representation, whether it's at the dean level. Little known fact, I am the first American Indian full professor at Johns Hopkins. That's not a pat on the back. What an indictment that it took until 2023 for Johns Hopkins University to have an American Indian full professor. And not just in university wide, not just in public health, but in the university, I'm the first professor. So, we're taking steps in the right direction, but what a shame that it's taken this long. So part of our goal collectively should be to agree that workforce development and ensuring that we have more equitable distribution of leadership roles is a vital part of the equation. When we think about our Indigenous-centered research, it's community-led. So we engage our communities and they let us know what their priorities are. We incorporate Indigenous worldviews, and even the whole idea of program evaluation. I'm sure we have evaluators, right? Who are a part of this discussion right now. But what I always like to remind people is that the word evaluation, at the core of that is values, right? What's important to us and how do we measure that? Well, unfortunately, what I've observed is that non-Indigenous values are placed on our programs, and then that's how we get evaluated. And that determines whether or not we get refunded, even if there's a values misalignment, right? There was one project I had funded through the CDC, this is 20 years ago. One of our outcomes was to have Indigenous elders connecting with Indigenous youth. And that was one of our outcomes. The CDC evaluator told us, no, that's not an outcome, that's a process, you know? Well, maybe from your value system, that's a process, but from our value system, it's an outcome. And don't tell us that we're wrong because our values don't align with the colonizers' values, right? So we don't do a good job yet of incorporating Indigenous or diverse values in evaluation process. Public health evaluation is such a vital arena, but we need to be smarter about it. We need to incorporate Indigenous worldviews, and we need to have the humility as a public health system to recognize that we could do better, that we have things to learn still, and that other populations have valuable input. The research is much more purposeful and personal. It's based on relationships that we build with the communities and with the individuals. And again, pushing back against colonial boundaries. The gold standard of research being the randomized, placebo-controlled prospective trial. That's all well and good if we're studying pills. It's easy to get a placebo. How do you do a placebo for ceremony? Seriously, what's a placebo control for Sundance? What's a placebo control for Sweat Lodge? What's a placebo control for prayer, right? So just because our systems are holistic and might not fit well into what modern science tells us is the gold standard does not mean that our systems are invalid. It just means we need to be smarter as a research community to develop methodologies that recognize that not everything fits within the nice tiny little box of the randomized controlled trial. So we have to have Indigenous methodologies and recognize that there's other ways of seeing the world, there's other ways of promoting health and wellness. So the other thing that we are really focused on is focusing on resiliency and recognizing that we have a lot of strengths in our communities, more strengths-based models. So instead of just looking at disparities, let's look at what are those strengths that are allowing many of our people to live in a very healthy manner. And what we're observing is that communities that have cultural preservation, thriving ceremonial practices, and language preservation are having better health outcomes. So we should be looking at that and investing in that and studying the impact of what is the public health impact of language preservation in a community. And it's just a powerful work that is really meaningful. So some examples of the work that I'm doing, we have a subcontract from the NIDA, so National Institute on Drug Abuse, the CTN, the Community Trials Network. And we're just about done with what's called the Great Plains Initiative. And we worked with 8 communities to do key informant interviews and focus groups to identify community-driven research priorities around addiction and recovery. So again, it's not just community-based participatory, but it's actually community-driven. And the data we've collected are just rich and powerful and focus on things like the need for culturally based interventions to address addiction and recovery. And what came out of this, one of the programs is doing what they call CAT. And I'm sure people have heard of MAT, the medication-assisted treatment for opioid addiction. So that's buprenorphine and related medications. What they're doing is ceremony-assisted treatment. And what they're finding is that when they incorporate traditional ceremony into the recovery program, they have less recidivism and they have much better patient satisfaction. And this is traditional healers, and they've asked us to study it. Isn't that remarkable? So the traditional leaders are asking us to study CAT, ceremony-assisted treatment. So that's getting started this year. We also have, through the Community Engagement Alliance, through NHLBI, National Heart, Lung, and Blood Institute, we just got awarded a grant just as of March 1 to start a holistic diabetes intervention in Rapid City. So some of our team members through the center in Arizona developed what's called Together Overcoming Diabetes. And it's an intergenerational approach where it's an individual diabetes and a younger family member working together to overcome diabetes. And it's not focused on things just like diet and exercise. It's focused on holistic health and cultural connectedness. And what we found is statistically significant improvements in hemoglobin A1C and BMI. So the project here is to culturally adapt that curriculum to Lakota in South Dakota and test it over time. So we're really excited about that project. Bristol Myers Squibb Foundation, we're very close to finalizing a grant opportunity to address lung cancer in our tribal communities, but recognizing that our tribes have had smoking for thousands of years, but they never had commercial tobacco, right? So many of our tribes have a relationship with traditional tobacco, which is actually medicinal. Even willow is a part of the herbal blend for traditional tobacco. So we need to have a better understanding of what is now the impact of commercial tobacco in ceremonial use. And we have, again, a group of community stakeholders that are participating in that proposal. So that's just a handful of the studies that we're working on, but there's a lot of really exciting work moving forward, and it'd be great to have more collaborations with the group here as well. So just real quickly on some of the international front, I had mentioned through the UN Permanent Forum on Indigenous Issues, myself, a few of others of us at the Center for Indigenous Health, but also an international team, developed what's called the Indigenous Determinants of Health. And it's not just negative social determinants like poverty, it's actually positive determinants like cultural connectedness. So this is available online if you're interested. The Indigenous Determinants of Health. We also had a summary published in The Lancet last year. And there's three larger categories on intergenerational holistic healing, the health of Mother Earth, recognizing that the health of the earth has an impact on the health of the people. And you might know that the Planetary Health Alliance has moved from Harvard to Johns Hopkins. So it's in the new 555 building in DC. So we're working collaboratively on an Indigenous Planetary Health Initiative. And then the third area through the UN was decolonizing and re-indigenizing culture as social determinants of health, and recognizing that, again, what we're seeing in preliminary evidence is that cultural connectedness is protective of health, and we should be funding those things and scaling them up. So I'd mentioned Indigenous planetary health, looking at Earth level determinants, and I'm sure people have heard the term Mother Earth, and it's not just a poetic or mystical terminology. If we think about it, as human beings, all of our carbon, all of our minerals, all of our water comes from where? The earth. Each of us is simply an outcropping of earth. So when we say Mother Earth, it's actually true biologically, scientifically. We are children of earth. So having a healthy earth obviously has an impact on the health of the inhabitants of the earth. Then other kinds of interconnecting determinants, and recognizing that we need to address the modern scientific paradigm, and perhaps there are indigenous approaches to preserving the environment that need to be included. And then a lot of work going on with Indigenous people's health related to climate change. And unfortunately, some of the communities, particularly like in the Arctic region, the Inupiaq populations, their ice is melting, and they depend on the ice for so much of their subsistence living. The salmon that used to be in the rivers in Alaska, many of those rivers have no more salmon, just gone. So subsistence living has been just decimated by climate change. So we're working on that. So just in closing, I do want to leave time for Q&A, but there's all kinds of potential solutions. And I'd mentioned several of them that we're focusing on developing the Indigenous public health evidence base. One of the things that we want to do also is develop an international Indigenous health database. We don't have comparable data across nations because we all collect data differently. So we're working with our international colleagues to develop that. I'd mentioned the International Indigenous Health Postdoc, a very exciting project. Also then respect and integrating Indigenous methodologies in the work that we are doing, and engaging our communities, focusing on their priorities, and then developing and honoring critical allies. And who are those critical allies? Well, it could be each one of you if you want to work with us as an ally and partner in these collaborations. So very good. And I'd like to end these discussions with a quote from Black Elk. And Black Elk was a Lakota spiritual leader from many years ago. And in the early 1900s, he met with a writer named John Neihart. And they wrote the book Black Elk Speaks. And this is my favorite quote from him. But of course, it was not I who cured. It was the power from the outer world. And the visions and ceremonies had only made me like a hole through which the power could come to the two-leggeds. If I thought that I was doing it myself, the hole would close up and no power could come through. And what he's talking about is humility. And that as soon as we believe we own the healing power, we lose our access to it. And I saw that in my own clinical practice when When our providers lose their humility, they lose their ability to connect with patients. And you know, we never hear patients complain that their doctor didn't know enough molecular biology, right? But we hear things like, my doctor didn't spend time with me. My doctor talked down to me. My doctor didn't listen to me. And when we lose our humility in medicine, we lose our ability to be healers. And I would put forth that in education, when we lose our humility, we lose our ability to educate. And perhaps as a public health educational arena, we could be more humble. Maybe we could recognize that there are unique components of history. There are unique cultural aspects of health that are not adequately addressed in our current systems. And if we're going to be part of the solution, perhaps we need to do that extra work of ensuring that Indigenous perspectives are included as we move forward in this very important and compelling work. So my email address, Warne1, and I'll go ahead and end it there and open it up for any discussion.
Wow, thank you so much. I mean, first I want to just thank you for a sobering and obviously highly educational. I'm sure many of us were like me, taking lots of notes, learning things that, and so in many cases we should have already been taught, have been taught. But thank you for opening our eyes, really to so much this afternoon. And I want to, I see it, folks coming in the chat, sharing the same sentiments as me. And so I think we're just all really grateful that you joined us today and told us so much about your work and gave us such a powerful and necessary history lesson as well. So thank you. I want to open things up for questions. And maybe as people are thinking of their questions, and you can certainly put them in the chat or raise your hand. Certainly a lot, Dr. Warren, that you shared today really does, I think, touch on many of the same approaches and that many of us are taking, and certainly at our work at the Center for Health Equity, lots of overlapping sort of themes and considerations. And so I know lots of us are excited to think about how we might collaborate in the future. But I certainly want to see if folks have questions now. And I see Dr. Cooper.
Yeah. Yeah, I just want to just chime in and with my thank you too for this just incredible presentation. So eye-opening and also just to say we appreciate the work you're doing and look forward to collaborating with you. I wanted to just ask, because you talked about Indigenous peoples in the United States and around the world, and I know that we have this tendency in the work we do often to sort of put people all into one big lump and one category. And so could you talk a little bit about how you address the fact that there are so many different Indigenous groups and populations with diversity within and across those groups? How does your center, sort of approach that diversity at the same time, like, maybe coming up with some principles? It sounds like you have some principles and practices that are across, that exist, like, regardless of that diversity.
Yeah, and thank you, Lisa. And you're absolutely right. There's a tremendous amount of diversity among Indigenous populations worldwide. And we've kind of coined a new term, it hasn't really caught on much yet, but the idea of English-speaking Indigenous peoples, ESIP, English-speaking Indigenous peoples. And because of British colonization, there's a lot of us. And then, ironically, if we look at it from a strengths-based perspective, that also means that we can communicate now. If I only spoke Lakota, I wouldn't be able to connect with my colleagues in Australia, for example, or New Zealand, or across Canada, or even in other tribes in the US, right? So we should be looking at that as a strength now, that we can actually connect with other Indigenous populations. And because British colonization was so pervasive and they followed kind of a similar playbook in many nations, we wind up seeing the same pattern of health disparities. And this was really starking to me. Stark to me because I presented at the Indigenous Diabetes Federation conference in Melbourne, Australia, probably 20 years ago. And I was on a panel with other Indigenous academics. And I addressed American Indian diabetes. There was an Aboriginal Australian academic and a Maori from New Zealand academic. And we essentially did the exact same presentation, over and over, but just insert Indigenous population here or there. So we have the really similar patterns of disparities, particularly across English-speaking Indigenous groups. So US, Canada, Australia, New Zealand, other Pacific Islands. But there are other Indigenous groups. So what we have found in some of our work through the UN is, as Indigenous populations, your colonizer matters, right? We had Portuguese colonization, we had Spanish colonization, French colonization, Russian colonization of the Aleutian Islands. So that's part of the framework, is to understand who were the colonizers and what were the outcomes. But for our current group, work, kind of by necessity, so we can communicate, it's primarily with English-speaking Indigenous groups. But excellent point, and an area of further inquiry and work that needs to be done.
Thank you.
Yeah, thank you for the question. And I did see a question in the chat. Indigenous
Indigenous determinants of health. Yeah, if you want to say more about that.
Yeah, so within that document, and I'll put a link in the chat as well, we recognize that the social determinants of health largely focus on a deficit space, right? So we see things like poverty, low educational attainment, housing inequities leading to health disparities. But in the Indigenous determinants of health, we recognize there are disparities. I put the link in the chat. That there's also strengths. And as determinants of health, again, there's some really compelling evidence looking at preservation of Indigenous language in a community leads to better health outcomes. Isn't that remarkable? It's in many ways not surprising, but it's remarkable that we're showing those correlations. But also cultural connectedness, participation in ceremony, all of those things have a positive impact on health. So it's not just from the deficit space. Indigenous determinants, recognizing that some of the long-term outcomes of colonization are things like poverty, but we have this connectedness to culture that's thousands of years old that's actually protective of health. So kind of taking a more balanced approach and recognizing that it's not just on the deficit or disparity base.
That's great. Thanks for that. Other questions? Oh, okay.
Hi. First, I really thank you for your presentation. And I was going to type this, but I think it's a bit too much. But in reference to your point about evidence-based medicine or evidence-based standards not being applicable for all, you've been so successful with getting funding for national and international work based on what I would presume are standards for which you're having to propose. If this is making sense, just how has that worked in that what you're proposing may not be applicable for the standards that you're being judged by to get your funding?
Excellent point. And it's been a longstanding challenge, hasn't it? I bet for a lot of us, where quite often the requests for proposals might include more holistic or diverse approaches, but the scientific review doesn't always match what's in the RFP. At least that's in my experience, that sometimes it's too indigenized, so we don't get funded. I think that there's, at NIH in particular, there's been a lot of improvements. They now have a Tribal Health Research Office, the THRO, Tribal Health Research Office. And they've been doing a lot of work in educating their own institutes, centers, and offices on the need for different approaches to Indigenous populations. But I'd say for all diverse populations, again, that one-size-fits-all approach doesn't always work, and it can really limit our access to those resources that we need to conduct research and develop programs. So I think we've been fortunate with the timing right now, where there's more open-mindedness to this work. And it also helps when we develop good manuscripts, good science and evidence base that we're contributing, so we can reference those in our application. So, but really astute observation. It can be challenging. So thanks for that question. I think Serena had a question.
Yep.
Yes, thank you so much for your presentation. It is brilliant. My question is, because as you were presenting, I did see some parallels, because I'm from Africa originally. I do see some parallels with regards to the indigenous people in Africa and how colonization affected their health, and how a lot of their traditional medicines were discounted as witchcraft. Do you know of any parallel work that's been done in Africa to with the indigenous people there?
Yeah, and it's a great point, as we see similar patterns, and particularly places like South Africa. There's so many parallels to the U.S. and what happened with colonization. So I know that there is work going on, but I haven't seen a lot of it coming from indigenous peoples yet. And I think that's the next step, is that we need to really build the workforce and more academics who are coming from the diverse populations that we want to engage, to lead the research and to even ask the right questions and develop the more appropriate hypotheses. I just a real brief story. When I worked at NIH, there was this was back in 2000, and PBS, Public Broadcasting Service, had a documentary on the growing problem of obesity in the United States. And one of our researchers, who was a brilliant diabetes researcher, endocrinologist, said that American Indians are exposed to the exact same diet as everyone else, but they have higher rates of diabetes, therefore it must be genetic. And this was national TV. Next day I went into his office and I said, well, what about the commodity food program? You know what he said? What's the commodity food program? So when our researchers don't have lived experience, they're not even going to ask the right questions. So I put forth, whether it's in Africa or anywhere in the world, we really need to grow the research community and leadership that really has that lived experience, and you can even ask the right questions in the first place. So, sorry for going down that rabbit hole, but I just agree that we really do need to have that broader focus. Yeah. So Tatiana, I think you're up next. Yeah.
Thank you.
Yep. Dan.
Thank you so much. Tatiana Warren here. And I just love today's presentation. I love these jam sessions. They get better and better every time. My question, or not necessarily a question, but more so a comment. I'm currently doing an evaluations project with the FDA, and their intention or push currently is around funding opportunities for minority serving institutions, that being HBCUs, HSIs, Hispanic serving institutions, and tribal colleges and universities. I would love to connect with you in terms of collaborators and PIs who you may know who are either having challenges getting getting funding specifically from the FDA, and maybe even hear from you on how we can enhance that process. Thank you again so much.
Of course. Yes, and I am aware of the opportunities that are available potentially to tribal colleges and universities, but we don't have a lot of those tribal colleges pursuing all those opportunities. And I think that's where we perhaps could provide technical assistance and help them get those resources to expand that local work. And there's a group called AHEC I put into the chat. That's American Indian Higher Education Consortium. They're based in the DC area. And that's the consortium of tribal colleges and universities. So they're a good collaborative partner. But I would agree that we need to expand more access to those resources in the community level, and the tribal colleges are a vital component of that. So I put my email address in there too, so feel free to reach out if there's potential areas to collaborate.
Thank you, will do. And I think it's twofold. The FDA works through cooperative agreements. So, sometimes the universities, the institutions just don't have the resources. But if they can collaborate with another institution, I think we can make that work. So thanks. Yep. I will be sure to reach out.
Sounds good.
It's been wonderful. One thing I think if others have a final question, please raise your hand or put it in the chat. But one thing that occurred to me was certainly it would be great if we could share training resources, as you were sort of mentioning that, both coming from our center, and then and when you were discussing Dr. Warren, the how most of the faculty at your center are actually based elsewhere in the US, it made me wonder if there are opportunities for trainees to actually sort of spend time, and it seemed like most were sort of in the western part of the country. Um, if there were opportunities there, so it'd be great to sort of share that information if there is.
Yeah, I think
Those sorts of
that's a
opportunity.
great idea. Where perhaps some people from your center, if they're interested, maybe there's ways to collaborate and even have placements in some of our field sites. Yeah.
Yeah. That'd be great. Well, once again, you can tell by the enthusiasm in the chat and the questions that people have that we all really, really enjoyed your talk today, and certainly look forward to connecting again soon, we hope. So thank you
Yeah.
so much.
Yeah. Thank you, everyone. Appreciate
Really
it.
tremendous.
Thank you.
And thanks, everyone. We'll see you in April, the third Wednesday in April for our next jam session. Enjoy the spring.
Mhm.